10-year-old child who on routine evaluation during a school screening program was found to be hepatitis B positive. What's the next to do and what the future holds for this child. So, how do you approach a patient who comes to this clinic? So, we should always remember that there are a few steps which are very important. We need to confirm the hepatitis B, we need to recheck and re-verify. We should screen for what was the possible source of infection if anybody else in the family is affected. We find out whether this is a new infection or an old infection. And then the big question is whether the liver is affected or not. And finally, to find out whether he needs treatment or not. And if no treatment is offered, what is the treatment? What is the follow-up plan? So, as per the guidelines, hepatitis B should be tested only by enzyme immunoassay or chemiluminescence immunoassay method. All other card tests don't carry much meaning and are not approved. So this is the method we use. And then once we are sure that this child or this patient has hepatitis B, we always try to screen for the close family members. There are strict guidelines as to who needs to be screened, but for all practical purpose, all the how context, if it's an adult, the sexual context, patients who have ever injected drugs, any individual who comes to the clinic with a chronically elevated AST/ALT level, patient with hepatitis C and HIV, patient on renal dialysis, all pregnant women, any patient who is in need of immunosuppressive therapy for any reason whatsoever, and patients who are uncontrolled diabetic, these are what the ASLD guidelines say should be tested. So this child was retested and confirmed to be positive by an ELISA test. Both his parents were screened to be hepatitis B negative. And since their parents were also not vaccinated at any point of time, vaccination was advised for the parents. Now, the parents wants to know, did the child get this infection recently or was the child chronically affected? So we ordered some blood test which should be done for all patients. We advise a liver function test and we do some tests which are related to hepatitis B. The AST/ALT levels were pretty normal. The hepatitis B DNA was done, which was pretty high, and he was found to be hepatitis B E antigen positive. And we did a fibroscan with a pediatric small probe and found that the liver was otherwise normal. Now, how do I interpret these values? So, what does hepatitis B E antigen means? E antigen means that the wild virus is multiplying. When the E antibody becomes positive, it means somebody who was having a multiplying virus have seroconverted, which can happen at the rate of 5 to 10% per year. DNA tells us about the presence of virus. ALT tells about inflammation. The other two tests, that is quantification and genotype, we are not doing in day-to-day routine clinical practice. So how do we interpret the results? So when somebody is hepatitis B negative, we do a core total. If it is negative and even anti-HBs is negative, it means that this is a person who is susceptible for infection and we offer vaccination. Now suppose this patient has a surface antigen positive, a core total positive and anti-HBs positive. This is where most of us will fall. This means that this means that this patient had an infection in the past and is immune to natural infection. On the other hand, if a person has surface antigen negative, total also negative, but only anti-HBs positive, this is a person who has received vaccination. In this child, if it is hepatitis B surface antigen positive, total positive, and all other things are negative, it means that this is a chronic infection. And on top of that, if you have an IgM positive, it means acute infection, or it can sometimes be reactivation. And very rarely we see a situation where surface antigen is negative and total is positive. This is a very unclear picture, which could be old infections or a false positive or a low level of infection. So this chart is very important to understand how to interpret the results of hepatitis B serology. Hepatitis B has four phases traditionally. In the young age, the body does not recognize the virus as foreign, and therefore the body doesn't react to it. Therefore, the ALT is normal. This is called the immune tolerant phase. This usually occurs up to adolescence. Then suddenly one day the body can realize that there is a foreign body inside the body, and it tries to get rid of the virus. This is when the SGPT levels will rise. This has been traditionally called as the immune clearance phase. That is, the virus is trying to, the body is trying to remove the virus from the body. In this battle, which occurs inside the hepatocytes, ultimately the body is in most of the time successful in reducing the viral load, but they reach a consensus where there is no further reaction from the liver, and the patient goes into a carrier state. And later in course of the disease, even when they are seroconverted from E positive to negative, there can be reactivation. So these are the four phases which we have been traditionally taught in hepatitis. In the first phase, the DNA is high, ALT is normal, no treatment is required. During the immune active phase, or the phase when the body tries to throw the virus, they are considered to be a treatment candidate. And when they become a carrier, this is where most of us get the patients in the clinic where they are E antigen negative, the DNA is low, ALT is normal. Again, they are not treatment candidate. And finally, in the later part of life, if there is a reactivation when the viral level increases, the ALT increases, they become treatment candidate. So to be very simple, when somebody has an hepatitis B infection, nowadays we are getting away with the nomenclature of carriers because this gives a false sense of security that a carrier can never get an infection. So the recent guideline says when somebody is positive, test him for E antigen positive or negative. In India, majority of the patients will be E negative. And then you classify them as chronic infection or chronic hepatitis. This is based on the principle that in chronic infection, the DNA levels will be low and the ALT levels will be normal. Whereas in chronic hepatitis, the DNA will be more than 2000 and the ALT will be elevated, and there can be some fibrosis on the fibroscan or ultrasound. E antigen positive adult patients we hardly see in our clinical practice, so I won't deal with this part of the algorithm. So this young boy had these reports. So this patient was in an immune tolerant phase. His DNA was high, but his ALT is normal, and therefore we decided not to treat him. And we asked the family to initially monitor the SGPT level every 3 to 6 months. And we told them that if any point of time the ALT increases to more than 70 for males and 60 for females, we will decide to treat. This boy was absolutely fine, and 7 years down the line, he suddenly developed jaundice one day, and his AST ALT increased to 650 and 200, and he was again E antigen positive. So, what do you think is the natural history of this patient? Which phase is his? So his boy has possibly gone into the immune active phase where the body is trying to throw out the virus. At this point of time, there are two schools of thought. Some schools believe that you can let the body clear the virus on its own, or you can give medications at this point of time, which continues for usually a lifetime. If at any point of time there is an icteric flare, that is, if there is a jaundice, but then you have to treat it immediately. So this child became asymptomatic. He underwent LFT after a few weeks. Again, we see the ALT came down. So this was the immune clearance phase. His E antigen became negative and antibody became positive. And we labeled him to be in a phase of inactive carrier, or what we now call it as E antigen negative hepatitis B infection. So this was the phase where this patient was. Finally, this boy went on, did his graduations, and then we told him to closely watch and monitor every 6 monthly his ALT, and he do an ultrasound and an alpha fetoprotein because HCC screening is required in this patient population. This boy went up and got a job, and then during a pre-employment checkup, one day he found that his ALT was again high. So DNA was more than 2000. This again brings us the question, which phase of the natural history do we think this patient is in? So if you go through this chart, you find that he has now become an E antigen negative chronic hepatitis B, or he is a E antigen negative chronic hepatitis B infection to a hepatitis. So he needs treatment at this point of time. So this is where we get most of our patients in real life practice. We will find patients who are E antigen negative, and the practical dictum that we follow is that if the ALT is more than 2 times of upper limit of normal, which is not of the lab that we are using, but consider 35 for males and 25 for females, and if the DNA is more than 2000, or if the imaging shows fibrosis or cirrhosis, or if there is a very strong family history of hepatocellular cancers, these are the patients where we start treatment. So this is how we approach the patients. There are various guidelines. I have summarized all the guidelines in one table, but for all practical purpose, a DNA of more than 2000, an ALT of more than 2 times upper limit of normal, or if there is fibrosis, either on a non-invasive test or on a liver biopsy, which is recommended in many centers for people above 40 years of age, are treatment candidates. So finally, this is your chart. B antigen positive, see whether E positive or negative. Check the ALT. If the ALT is normal, just follow up. If the ALT is borderline between 1 to 2 times, you can repeat the liver function test a little early. If greater than 40, you can do liver biopsy. If there is more than 2 times, we treat. And a similar algorithm is for E antigen negative, which is mostly for Indian patients, where the DNA of less than 2000 is considered to be more like an inactive. But if it is between 2000 to 20,000 or greater than 20,000 for E positive, then we start treating these patients. I will not go into the details of the medications because it's a 15-minute talk. So for the shortage of time, this has just been how we approach a patient who comes to the clinic with hepatitis B positive and where we decide to start treatment. Thank you so much. It'll be open for questions.
Thank you. We'll take the questions at the end.
Yes, sir.
And many thanks, Dr. Mithun. You have clearly told us when to interfere and then when we should keep quiet and then keep on observing. Now we will hear from Dr. Anand Kulkarni. Unmute yourself, please. And he will tell us, a patient has come, there is acute hepatitis already, enzymes are elevated, how to go about. Of course, Dr. Mithun has already told us how to go about if it is a hepatitis B infection. Dr. Anand will tell us now about how to go about for the acute hepatitis. Go ahead, please, Dr. Anand.
Slides are visible, sir.
Yeah, slides are visible.